Hello there. We are the Kaleidoscope team. That's a good start for us there. And we write the Kaleidoscope column in the British Journal of Psychiatry. So if you're new to this, every month we present some papers from our Kaleidoscope column. And we have three this month we're going to talk about. We're going to talk about one to do with cannabis and driving. And then we're going to look at two trials where methodology is discussed. Who do we include in trials in psychosis? And what do we mean when we say depression is hard to treat? So we're going to start off with the cannabis one. What I'm going to say at the beginning, if you've not been here before, we really like if you put chat in the side. I always find it fun if you tell us where you're from. That's fun for me if you want to do it and say where you're joining us from. And if you have any questions or comments on the studies themselves, do put it in. We'll try to get to as many of them as we can. So the first one is cannabis and driving. So in the UK, and this is why I'm partly curious about where people are from, you can drink and drive in the UK. It's discouraged, but you're actually allowed to do it. There's a limit. And so there's an argument about should you ever be allowed to drink and drive? And of course, some people would say no. So what about when it comes to drugs? Should you be allowed to take drugs and drive? In the UK, you can get tested. The police can stop you, but they often don't test you unless you roll down your window and it's honking of cannabis. They often won't test it. So should they? The law in the UK says you cannot take any drugs and drive. But I don't know if you've met people before, people seem to take drugs despite the law saying you can't take them. So is prohibition a good thing? This study is interesting in the sense that I'll come on to Dawn now, is going to talk us through it. But what I found interesting just to start off with is it's kind of a real world approach. So studies up till now have tended to be somewhat artificial in that they give the active ingredient THC, but in quite controlled artificial amounts. And that's not how people consume it, as I understand it. But Dawn is our expert in that. So what did you find in this paper?
Yeah, there's actually so much, and it really does all come together in terms of things that are happening in almost a natural experiment, particularly in the US. So this paper was from the University of California, San Diego group, and they were trying to address just this, that we have in the US kind of this mass expansion of medicalization and legalization of cannabis. So people have access and every right to that access. And having met people, we know that unless there are very, very, very clear rules, and even then, we're going to see some behavior that's perhaps questionable. And where we're falling down in terms of really helping people make smart decisions about their choices in regards to driving, etc., when under the influence, is that we just don't have particularly excellent data on it. Studies that have been done are relatively small scale, as you mentioned. Also, they tend to look at low dose potency. But if you recall one of our very early day Kaleidoscope lives where we talked about marijuana before, you'll remember that if you're doing experiments with marijuana and human subjects in the US, you're getting it from NIDA, which has got a big old farm in Tennessee, and it's going to bring you a very different product, very different potencies than what you're going to be able to access at your local dispensary or street corner. So with all of that said, even what we know probably isn't enough for us to feel sure in any way. And so they sort of tried to attempt to give some real world, I think, credence to this while keeping it relatively controlled. There's a joke in California that the reason that there are minimum speed limit laws is for everybody who has any cannabis on board and then ends up driving. The joke being that they're sort of quite slow to react, that you don't have to worry in the same way that you would with sort of alcohol. And I think that's the thing is what we see in terms of laws are really related to what we know about alcohol, which has a particularly linear effect between blood concentrations and then behavioral impairment. So we're kind of balancing what we don't know about marijuana with what we do know about alcohol. And I think this paper is attempting to maybe bring those two together and see if they make sense in any way. What they did was they actually looked for people who are already regular cannabis users. Obviously, that has its own limitations. But what was great about it is they said to them, right, we're going to bring you into the lab and we want you to essentially smoke to your desired state of intoxication, whatever you do normally. So you get this kind of real world effect. And then they put them through a driving simulator. I don't actually know how you're trained to drive here, but in the US, it is a great rite of passage. In high school, you take driver's ed and you do a lot of watching of horrific 1970s videos. And then they put you in these big sort of machines that were the precursors to video games. And you do what is the most boring video game in the world, but they set them up to do these driving tasks and they record all kinds of things, reaction times, overall scores of driving capability, different kinds of distraction, lane drift, you know, all these specific things. But it's a great way of collecting data in a real world simulation without harming anybody. So that was the approach they took overall. In the end, they actually were able to, simulation like pilots do. Exactly, Tomoko, exactly. Oh, do you not have it in the UK? I'm seeing from the chats. Sorry, I know you can't read the chats as well, but I'm seeing in the chats that in fact, you do not have these amazing machines and highly recommended. Anyway, with all of this, right, we have to take into consideration what's happening in people's bodies at the same time. So there's recommendations on cough medicine and all of this. They bring these guys into the lab and their questions are really real world questions. This idea that, right, you legally have the right to marijuana. How long should you wait after you've ingested before you get into a car? Do you accurately know how impaired you are, right? This is something that we know happens with alcohol all the time where people feel very, very fine to drive and in fact make terrible choices. So trying to look at kind of what is the magnitude and the time course of the effects, how it looks across different amounts. So what they did was randomly assign this group of users to 3 different groups. There was kind of a high THC concentration, I think it was on 13%. There was a medium at about 6%. And then there was basically effectively the placebo, which was, again, sort of a marijuana rolled cigarette, but it only had 0.02% THC. And again, they had 10 minutes. They could smoke to their desired level of intoxication, though they were required to minimally take 4 puffs. And what they found, not surprisingly, is that people who ingested THC were worse drivers than those who had not, who had the placebo. And it was particularly evident not only on the overall scores, but on what we call divided attention tasks. So the kind of stuff that, you know, maybe if you're just going along the road and nothing is happening, you'd be okay, but heaven forbid somebody calls or a deer runs across or whatever, that's where you're going to get into trouble. And what was interesting, they stopped them at different time points and they asked them things like, how high are you? How impaired are you? Would you drive like this normally? You know, are you a good driver right now? Those kinds of questions that I think are really actually the foundation of self-evaluation when people are making these decisions about getting into a car. And they found that at 30 minutes post-administration, 50% said they would drive. And when we get to 3 hours, 90% said they would drive. So you can see quite a steep trajectory around confidence levels. And what was interesting though is the ratings in terms of how well they felt they were driving in comparison to people who hadn't administered any THC was only different at the 30-minute time point. They only were conscious that they were being impaired in any way up to the 30-minute time point, though they didn't say they would drive in mass until about 3 hours. So what we found overall is that for sure it affects driving. Overall, the driving effects were evident until 4.5 hours after. So you see that there's actually an extra hour there where people feel fine to drive, but in fact, there's still impairment. And what was the most interesting to me was this idea that in fact, the blood concentration levels actually had nothing to do with what we saw in terms of impairment. There was no kind of linear relationship there between THC levels and the types of driving we saw, which means that, in fact, all the laws based on this are basing themselves on alcohol and not the situation at hand, at least according to this data. It also showed that people have a real lack of insight in terms of their levels of impairment. And again, when you're impaired, it's not a surprise that your judgment would be impaired, but actually now that we know, we can say really confidently that people can't necessarily make those decisions. It's particularly important to roll it out, I think, further. But again, this idea of real world, counterintuitive. I see some folks talking about the idea of subjective effects and the results being somewhat counterintuitive. So I totally agree. What I want to come back home before I release it to you guys too is this idea that this is real-time stuff happening in the US. We have all these states adopting legalization and medicalization. And there was another paper that came out this month in JAMA Open that was looking at the incidence rates of cannabis use disorders in those who had been given medical marijuana cards. And they were able to, for the first time, basically take people who were all approved, but half of them got to have access to their card right away, and the other half had to wait 12 weeks. And these were folks who were given the card for anxiety and depression, as well as pain management. And what they found is actually, of course, for the folks who had the card, they had higher rates of use disorder, but they also got no benefits to pain, anxiety, or depression, though they all slept better. But the cannabis use disorder was particularly profound in the groups related to anxiety and depression. So unlike other things we talk about here, where you are working in concert with a medical professional to choose what is a standard treatment with a known sort of profile, we have people walking into dispensaries who are staffed by very knowledgeable people, but not medical professionals, and effectively having almost more of a drive in their own care. And we're seeing, I would say, public health related consequences, not just potential addiction related issues, but public safety in terms of driving and things. And so I want to bring it all together because I think that there's something happening in the US, and I think it would be amazing to talk about that in full.
Wow. Silence.
That was an amazing précis of the paper. Thanks, Dawn. And I admit that I didn't read it nearly as carefully as you did. The thing that surprised me about the finding that surprised me most was that there doesn't appear to be a strength response association. So there wasn't a difference based on THC content as I understood it. But I guess that doesn't speak to, I don't know how you could measure tolerance if you're a chronic user and then you're allowed to puff away for 10 minutes before. So I don't know if you can extrapolate dose response rather than sort of exposure to concentration and response. And I think they are subtly different because we know with nicotine users, for example, that they will smoke as many cigarettes as they feel they need to, but they'll inhale less when their nicotine saturation threshold is reached. So you'll continue chain smoking, but you're not really inhaling. Sounds a bit like Bill Clinton all of a sudden, doesn't it? But and the thing, I mean, it's not a particularly scientific observation, but Dawn, I wanted to ask you about this. If you look at the funding and support for this, it was funded by the state of California via the Assembly Bill 266. And I don't know what an Assembly Bill is, but my guess.
What a great question. I didn't even see that. I'm so glad you raised it. So assemblies are legal bodies that are associated with states. So we in the US have kind of an overarching federal law, and then each state has the opportunity to create their own laws as long as they don't properly butt heads with the federal one. So the state assembly is a group of legislators that work together to pass bills in regards to the citizens and operations of the state of California. So I suspect, because they were one of they're early adopters in a bunch of different ways, and this was one of the ways. And it's, you know, many states have an economic incentive effectively to begin to figure out how to work in a natural way with the marijuana industry because it can generate so much revenue, particularly in an agricultural state like the US. But we're not from the tourism board. But what I was saying was that actually this is government sponsored work. And that tells you that in some ways, obviously they're interested in driving laws and how to attack them because we have laws, but they're not research informed. So that doesn't feel good or confident. Yeah, I wondered.
That's the reason I asked the question. Sorry, Dawn. That was my reason for asking, was because I wondered if this was a direct, they almost contracted this particularly expert group on substance use at San Diego. Was it San Diego?
Yeah.
Yeah. Sorry, I wondered if that was the reason they did it, was they wanted an evidence-based law.
Yeah, I think so. But again, the fundamental flaw here is what is the THC they're using, right? So again, if we're still pulling from the NIDA farm and we're still going to Tennessee for this stuff, then we aren't getting what's in the Humboldt dispensary up in the Redwoods. It's not happening. So it's informative, but it isn't necessarily as I don't know, translational as I would hope it would. But I want to go back to your point about dependence and tolerance. And I was thinking too, like all of these studies actually, they're not addressing behavioral tolerance, right, at all. So people just get good at functioning in a slightly impaired state. And that you're not going to see so much in a blood level and stuff. So all of these things are very nuanced.
Yeah, it's an interesting set of findings, and particularly I'm always interested in studies where you have a subjective and then some sort of objective measure, and the disparity between the two I think is quite revealing, because I've heard people who use cannabis regularly say that the difference between, this is all anecdotal, but I've heard a number of people tell me this, the reason they feel confident driving when they've taken cannabis is because it can be overridden by your adrenal glands. So if you're driving along and suddenly you panic because the car in front of you swerves or stops suddenly, their argument is you can snap out of being stoned far more quickly and more reliably than snapping out of being intoxicated with alcohol. I'm not sure I buy that story, and this would seem to suggest that that's not true, right? If you've got, a 4-hour window before your performance returns to baseline, and there was a within difference design and analysis, I think. So I think they can be reasonably confident that stands. But yeah, I thought it was really interesting for that reason. People, were more confident in their driving ability than was actually demonstrated. Yeah, and I don't know how to interpret the dose issue at all, other than I don't really think we can conclude much from it.
Any thoughts, Natsuki?
I thought it was, in a way, there's no news that cannabis impairs your psychomotor function. I think that's pretty well established, right? Nobody's denying that. I guess the only interesting things that come out of it for me were the fact that the blood levels didn't correlate with behavior. And if that's the metric that you're using, like you're waiting for somebody to be impaired, demonstrate impaired behavior in terms of their driving, you pull them over, you test how much cannabis they've got in their blood. If there's no correlation between that and behavior in these kind of lab-based studies, then that suggests you could either be quite impaired and have very low levels, or you could be, not impaired at all and actually have very high levels. And so it's not, if you're going to use levels as a kind of way of assessing whether people need to go to court or something, that strikes me that that's not particularly efficient. The other thing which kind of confounds it a little bit is the fact that actually, I think the drug level, and you can correct me here if I'm wrong, Dawn, is that the blood levels are actually higher in the people who took the kind of low intensity, like the 5%, rather than the 13%, which was a little bit odd. And then I think that's the reason why they invoke this idea of tolerance, and the thing that Dan's talking about, where you're kind of effectively, they make this argument that maybe people just titrate to a certain point. But there's no evidence of that, just kind of comes out of the blue off the back of the data. And I think one of the things that you might want to be a little bit careful about is that all of these folk had previously taken cannabis. That was their kind of selection criteria. And I think like 92% of them, when they were asked to guess whether they got the placebo or they got the real thing, were able to do that accurately. So there's also, like any other drug, there's going to be an expectation effect in terms of what you think is likely to happen once you're taking cannabis, once you already know. So I guess that means that actually the placebo condition that they're using as a kind of control for anything is not quite as pure a contrast with, because it's not that people are genuinely blinded into 3 conditions. Actually, they're not blinded at all. You may as well, if 90% of the people can tell, there's no blinding going on, right? Effectively, only in the 8% who couldn't figure it out. So I think that also causes an issue in terms of how you interpret that, although that's quite a subtle point.
I think that's actually a really important point, because I think this really does only apply to these experienced users. If we had novel users, that placebo would be it would do its job much better, but I bet we'd also see significantly higher impairment. And I think too, the point that you make about the idea of self-titration, they only said it once and kind of let it go. But from other drug literature, what we see a good portion of the time is that experienced users are, they kind of know the internal cues. And so in these lower groups, actually, they instantly recognize they're not getting what they need. So they overtake in order to achieve the level that they desire. And that can mean they're shooting the mark, especially if they say, you have 10 minutes, ready to go. So they didn't address it in any way, but I actually wonder if it wasn't a sort of, oh, got a race to catch up kind of response. But again, that was not in the data. I'm totally reading between the lines. But yeah, I'd really like to see this one replicated in novel users, because I wonder if there isn't a more pure, maybe not linear, right, but a more purely plotted relationship between blood levels and, you know, you won't have the same tolerance effects. Yeah, I just think it'd be nice to see that mirrored again.
You're suggesting at the moment it might be a good day out going a driving simulator and getting stoned. So that might be partly behind this. But I still think, I wonder about a public health message in that, even so, people who have been consuming cannabis, and I think Sarah mentioned this in the chat, that people who have been consuming cannabis, their performance is inhibited. Because I think for some people that they say that it isn't. And, you know, you can argue that legislation should do A or B. It's currently illegal completely and people do it. So I feel that legislation is not the way to approach this, but it's something about public health. And maybe there's a messaging out that it will impair you. And also you're probably not going to be so good a judge about when you're fit to drive, which kind of fits what we might think with alcohol. Let's move on to the second paper. And we're going to think about trial methodology here as well, but with RCTs. RCTs are randomized controlled trials, and the first two letters perhaps the most important. So you randomize, you break people into different groups. One might get an intervention, one might not, but it's the control part we're interested here. So if you're giving an intervention, say a new drug or a therapy, you tend to want to make sure that it's the intervention or lack of it that's causing the effect. And so you control for other things. For example, you might not include people who are smoking cannabis because maybe that will impact your results. But you're going to tell us, Dan, about a paper that challenges the applicability of randomized control trials, or the people are included within it.
Yeah. So this paper excited me because it speaks to an ongoing debate about evidence-based medicine. And the debate is as follows: is if for a randomized controlled trial, you usually have two interventions that you want to compare. And to do that, very often you want to compare the average treatment effect between groups A and groups B, so intervention A and intervention B. One of them could be placebo. But importantly, you want to do that on a sort of an even or a fair basis. So you want to make sure that the patients that get intervention A or treatment A and treatment B are as close to each other as they possibly could, or that they don't differ in important ways. So there's lots of arguments for randomization in controlled trials. There's lots of arguments for having tight inclusion and exclusion criteria to make sure that you're studying the average treatment effect you get between groups is actually a treatment effect and not attributable to other factors. So randomization is supremely useful for this. Inclusion exclusion criteria are the way of ensuring that you're getting a pure effect, if you like. You're actually seeing an effect on the disease process that you're looking at, rather than, say, some other factor that you can't quantify. So the problem is we've got a whole literature of RCTs that show us that different interventions work for different conditions. But the argument that you very often hear is that, and quite often it's not a very well articulated one, but it's anecdotal. It's like, yes, but in my patients, this medication or this particular psychotherapeutic modality works, right? So you've got this disconnect between the RCT evidence and people's clinical experience, so clinicians' clinical experience, but also the way you see the performance of these interventions in everyday clinical populations. And one argument, and it's been used, I would say, really inappropriately against using RCTs. So one argument from, dubious ends of the scientific literature is we shouldn't do RCTs because, and I think this is the problem, is it does the people who are in RCTs, people who get included because they meet the inclusion but not the exclusion criteria, do not represent the patients that you typically see in everyday clinical real-world practice. So that argument can be weaponized and has been really well weaponized by certain communities, but it's a valid point. It's, their answer is wrong, but their question is right, I think. So the problem is how applicable are your RCT outputs, the evidence that you garner from multiple RCTs and then meta-analyses of them, to the actual patient that you're sitting in front of? And the answer, as it turns out, is, at least if you listen to these studies, it's not very much at all. So what they did is, in a Finnish and Swedish registry, national registry data, they located people, 25,000 people in total, who all had used second-generation antipsychotics for at least 12 weeks, and they included people where they could follow them up for 1 year of maintenance treatment with the second-generation antipsychotic. If of those 25,000 people, they then applied common inclusion and exclusion criteria from the RCT literature looking at relapse prevention. So they took a bunch of trial criteria and then applied them to these 25,000 people. Now, the headline summary here is that only, 79% of that 25,000 people would not be eligible. They would be ineligible, excluded from RCTs. So that headline tells you that the populations that are being studied in RCTs of relapse prevention in schizophrenia or schizophrenia-like psychotic disorders appear not to be representative of the patients that typically are receiving them in routine clinical practice. If you're willing to accept that those patients mined or located from registry data represent real-world patients who are being treated. So that was the first headline. So RCTs appear not to be recruiting the same kinds of patients as the patients that receive these medications for relapse prevention. The other thing they did that I thought was super important was if you now have a population of 25,000 people divided into eligible or would be eligible and would be ineligible. What they then did is looked at hospitalization rates in both of those groups. And this is really interesting because if the evidence in a relapse prevention trial suggests that you should continue with a prescription of risperidone or a long-acting injectable medication and so on, then what you really need to do is look at an important outcome for those two groups. So they took the patients and they looked at risk of hospitalization, the argument being that if your medication is working, then you shouldn't need to be readmitted to hospital. So that's an important outcome, I think, in these trials. So what they then did is look at that in the ineligible and the eligible group, and they found that when you compare the ineligible group to the eligible group, the hazard ratio was 1.14 to 1.47. So that means you are more likely to be someone who's at risk of hospitalization if you're ineligible for randomized controlled trials. So that speaks to the degree of illness. So not only does it say that the ineligible patients, does it say the RCTs aren't selecting the same population as the people that end up being treated with these medications, but in addition, the hospitalization issue speaks to severity of illness. So it would appear that the ineligible group are more likely to be hospitalized, and you could infer from that more likely to be more difficult to treat or have a more severe illness. Then they found that in the people who were ineligible and were hospitalized, they found that the factors that were most associated with relapse and hospitalization were treatment resistance. So that's evidence that the patient had treatment-resistant illness, tardive dyskinesia, and a history of suicide attempts. So not only could you argue that we're not capturing the same patients that end up being treated with those medications in randomized control trials, it would also appear those people that aren't making their way into controlled trials are more ill and more likely to be hospitalized. And in addition, they're more likely to have evidence for treatment refractoriness. They're more likely to have tardive dyskinesia, which you would normally associate with longer-term treatment and longer-term treatment with first-generation antipsychotics. And these are people that have a history of attempting on their own lives. So the papers, I mean, it's a really detailed paper, as these registry studies often are, with lots of really carefully constructed analyses. I think it's a brilliant paper, and I think it tells us a lot about how we might, in the future, pursue how we use randomized control evidence when we're looking at personalizing treatment for an individual patient. So I think it's a really important paper in that it speaks to an intuition a lot of clinicians have, which is that RCTs don't really measure the same thing. It points us towards more pragmatic designs. So one of the things they mentioned in their discussion is we should do more KT and STAR-D type trials. And so for those that don't know it, KT is a classic study of a pragmatic study of different antipsychotics for schizophrenia, and STAR-D is similar design, but for treating depression or working out how to stage the treatment of depression. So that's my spiel about the paper. I just think it's a really good paper that makes some really important points in a really robust way, and it makes us think twice about how we might in the future. I'm not saying we should abandon RCTs. I'm not weaponizing the paper, but I think it does tell us about how we might think about how we use RCT evidence to make individual recommendations for treatment.
I actually think it's an incredibly well-written paper. It's an incredibly well-done paper. And I wonder if it isn't speaking to sort of more broadly, like a moment in time, right? Because if you look at anything that we do when it comes to human beings, we start with what works, and then we recognize that that actually isn't a nuanced enough question, and then it becomes what works for whom, and then that still doesn't work, and it's what works for whom under what context. And I think maybe this is that natural evolution, what you needed to get a gold medal in the Olympics in gymnastics in the 1970s versus what you have to do today, or what you needed for a Nature paper then versus now. And this idea that, you can't just chuck them out. Like you said, certainly not to weaponize this, because you can't sort of baby with the bathwater, right? Part of the scientific pursuit over time is that you start simple so you can get robust findings, and you use them as a base, and you build your sort of bricks from there. And I wonder if in fact this isn't just the moment in time where we take a look at this, what has been such a generous tool for understanding. The RCTs were absolutely pivotal in so many different areas, and whether or not we say thank you, we respect your contributions, and now what we need to do is build, just a little bit more. And maybe that's just a little bit too placid, but my take is that they don't have to be bad to need to be improved. It might just be a nature of the fourth dimension of time.
I think I totally take your point, Dawn. I think that's the appropriate weaponization of this paper. I think that the point is that there's lots of very important statistical reasons to use randomization. There's lots of really important statistical reasons to use control. There's lots of good arguments for having defined inclusion and exclusion criteria. There's also a really good argument for defining your outcomes properly. Yeah. And those are the important takeaway messages. But perhaps the one pragmatic thing we can take away from it is you should retain all of the rigor of RCTs and all of the statistical principles that inherit from that, but we maybe need to think differently about the notion of a pragmatic RCT in the spirit of Katie and Star D, because we need to know a bit more about, we can't meta-analyze RCTs where only 20% of the population with that disorder would be eligible for it, right? That disparity, I think, holds as a prima facie true, or true prima facie, I don't know, I'm mixing languages and metaphors now, but it is obviously true that you can't use evidence if it only applies to 20% of your patients. The thing that I think the reason I got excited about this paper is there was a paper a couple of years back that I came across where they were making an extravagant claim for an intervention in psychosis. And not only that, but making an extravagant claim that this intervention would be applicable to everybody with psychosis. So for fun, I took their inclusion and exclusion criteria and ran them over the Katie data set, and I discovered that only 17% of patients would be eligible, right? So my frustration with the paper that was overstating its claims was, for everybody with psychosis, we should be giving them this intervention. And actually, I just thought, well, if you were to take the Katie population, which is a fairly typical population of people with a 10-year history of chronic schizophrenia, well, you would only allow just under 20% of them in. So how could you possibly say that? So that I think that's the reason it excited me so much, was because its findings were not dissimilar from a back of the envelope calculation I did on another study that I think was overclaiming. So yeah, I'm sorry, Dawn. I'm just agreeing with you, Dawn. I'm not actually adding new information here. Sorry.
I love the back of the envelope calculate across mass data sets. Just to check a hunch. I think that's a fabulous characteristic.
I think from a time point of view, we should take this on to Suki and the last paper that we're going to do today, which is looking at a different thing in terms of trials. It's looking at depression, and it's looking at names. So what is in a name? You might be aware, in terms of some studies in depression, there is a thing called treatment-resistant depression. So that, in a sense, that feels self-explanatory, but that's not a term that lots of people like. So sometimes people feel that's a bit blaming, that they're not getting well when it's not their fault. And there's a paper you're going to talk about, Suki, that challenges that as a construct, or tells us that it might be simplistic and there's a better way of of thinking about depression, and that this impacts how we understand trials?
I think it's kind of speaks a little bit to the paper that we've already looked at in terms of how representative are the folk, or how representative are the designs that we're using for the questions that we have. So the paper that we've just discussed with Dan essentially says that the sample that you collect or use in your trials may or may not be representative of the wider population. And I saw that Sarah Imanova had made that point there, that actually, if you're testing things in people where actually 80% of the folk are outside that test sample, how do you know that it will have an effect in all of the people with that disorder? And actually, one of the things that comes out in that paper is the fact that the authors backtrack a little bit to say, I know we're saying that 80% of the people weren't eligible, but actually we want you to know that we don't think that that means that antipsychotics won't work in those people, because the actual differences in the hazard ratios are relatively modest. So it's not like, but what we're saying is that within that, there's probably going to be some subpopulations which may be difficult. One of those subpopulations was this treatment-resistant folk. So here, the question's been, in this paper in Psychological Medicine, by some very eminent folk doing a lot of clinical trials work, probably the leading lights of that kind of area, have focused their mind on what happens in terms of a subpopulation of patients with depression that don't respond to our treatments. And they say about a third of people who are treated for depression don't achieve kind of symptom remission, even after several trials. And again, exactly like the last paper, they make the point that these people who don't respond are often excluded from the clinical trials. So therefore, actually, you don't have data in these people. And therefore, they're saying maybe we need to look at what they call this difficult to treat depression group separately. And once you've established that somebody is difficult to treat, i.e. they haven't responded to a certain number of trials, that maybe the therapeutic focus needs to shift from trying to get a symptomatic remission to actually trying to get symptomatic control. So actually you've given up on the idea of curing everything and getting things back to normal. What you've decided is what are the key factors that are interfering with the person's life, what are impairing them, and can we help just focus on those? So whether it's optimizing symptom control, whether it's looking at their psychosocial function or quality life, or you're trying to reduce the risk of deterioration. And then they make the analogy with the epilepsy literature, where they're saying the more trials you fail, so if you fail one medication, you've got a 48% chance of remission. If you fail on 2 sequential medications, you've only got a 28%. And if you fail on 3, you've only got a 16% remission. So they're saying the more you have these failed acute trials, the lower your eventual remission rate and the higher your rates of relapse, even if you do get better transiently. And they say, well, how will that be beneficial? Like if you say that this person's difficult to treat, and their argument is that those are the people where you would want then to test novel medications, combinations of different medications, combinations of medication and psychotherapy, and the new kind of neurostimulatory methods and more novel, innovative things like intensive outpatient programs or peer-supported programs at these particular folk. And in terms of designing better studies in the future, they look at 3 broad areas. One is around participant selection. How do you select the people who are you're going to say are difficult to treat? And that's not quite as simple as it looks, because you need to define, do you just say that any treatment, as long as you've had 2 of them? And so that might be drug treatments, might be brain stimulation treatments, might be psychotherapies. Is that enough? Or do you want to say, actually, to be defined as difficult to treat, you need to have had a systematic sequence? So a sensible one might be that you would start off with psychological therapy, and then you might choose something relatively benign like an SSRI, a serotonin-specific reuptake inhibitor, something like fluoxetine. And then you might, if that doesn't work, you might augment it with an antipsychotic, which is a current practice. And then things are difficult, you might move on to augmenting with a monoamine oxidase inhibitor. And eventually, if that didn't work, you might move on to ECT. And that would be a pathway where you would be able to define that this person was clearly difficult to treat because you've tried all of those things. So that's one of the questions they raise around this participant selection. The second thing is about outcome assessment. So all of the short-term trials are focused on reducing symptoms. So they say basically you add up the number of depressive symptoms somebody has. If you go above a certain number, you say this person's clinically depressed. And then with treatment, you expect that number to go down. And they're saying these short-term acute trials, usually like 6 to 12 weeks, are not suitable for these patients who have this difficult to treat kind of depression, because those are too short term. It doesn't tell you enough about what's going to happen to them over the longer period. So maybe you need to have a think about how you're going to do that. Similarly, is it more important for you to fractionate the symptoms of those, including rather than just using the total number? Because if you're only going to aim to control some of those symptoms and you're not looking for remission, then you might want to actually have a focus on whether it's insomnia that's bothering them, or anxiety, or irritability, or cognitive impairment, or whether they're abusing substances, for example. And similarly, the timing of your assessments are going to be critical. And they mentioned the fact, so with the new drugs that are on the market, like esketamine, that actually, if you give the infusion, you see an effect within hours, but it may go away after a week if you don't repeat it. But if you're using other new technologies like vagus nerve stimulation, for example, it might take months or years for that to start working. So therefore, the timing needs to fit with the approach or the intervention that you're looking at. And they particularly focus on the fact that different outcomes may need to be collected at different times. So for example, depressive symptoms might improve before you start seeing a change in functioning, in social functioning, or the quality of life. So therefore, you might want to be doing those at different times of the actual intervention and in your outcome assessment. And then finally, they kind of finish off by saying that essentially you need to think about 3 areas of trial design, which are around this kind of sample sourcing. Where do you get your sample from? Is it representative? Coming back to the question from the paper before, and how do you do that in a real world way? And the second thing is about the issues around how you execute the trial, the outcome measures, and when you're doing the measurements. And then the final thing is about doing how you design your intervention studies, that you can look to see that there's a causal inference in the chaining of events between what you're doing and the outcomes that you see, and they're temporally related in the sequence that you look at them. So it's quite a complex paper, and in a way it reminded me of the kind of clinical work that we do when I was working on the National Psychosis Unit, where we had a lot of difficult to treat patients with psychosis or schizophrenia. And there, the attempt to classify those people was complex, and the approaches you used to manage them were often focused on controlling symptoms, identifying the ones that were really impairing and trying to fix those if you could, rather than trying to aim for remission. And even systematically collecting the data, these guys make the argument that there's no real tools for them that you can just use, which tells you which medication they've been on for how long, what's the duration, what's the dose, were blood levels done, was it effective for any particular symptom profile, and so on. And they bemoan the fact that electronic health records are so poor at being able to extract this really useful and essential information for these kind of classifications. Okay, over to you.
Who wants to have the final word?
I will happily jump in very quickly to leave a little room for Dan, but it occurs to me that all of our papers actually today are themed around the great need for nuance and the binding problem that we have between the science we do and the people we serve, and that we haven't quite matched that up yet. But I was struck, Suki, just in the way that you were talking about the paper, and maybe this is just my misunderstanding, but I saw real parallels with the ideas around harm reduction rather than abstinence in addiction literature, and the fact that, again, we have to be thinking about the people we serve, and sometimes that total eradication is not necessarily the goal or desirable in terms of its cost. And instead, what we do is we serve the human we have. And again, all of these things just feel very connected to me around the importance of nuance and centering people and the service that we do for people.
Well, I think we're going to leave it on that point today. Dawn's wisdom is always a good way to end it. And of course, our message, don't take drugs and drive. And we hope to see you next month. Take care.
Bye all.